All right, can you see the appropriate slide?
That looks right.
Okay, great. Well, good morning, everybody. And I'm happy to finish out the CKD continuum and talk about depression and non-dialysis CKD. I did change the title of my topic as pre-dialysis is presumptuous. As we know, dialysis is not for everybody. This topic is inspired by my patients, many of my patients who struggle with depression, both non-dialysis and dialysis. However, today's talk is going to focus on the non-dialysis patients and explore the question, is there hope? Make sure I have my little pointer. All right. So let's begin with the case. Mr. B, he's a 35-year-old with non-albuminuric CKD B3, likely due to hypertension and cardiorenal injury. His creatinine was 1.3 in 2017 and peaked at 3.4 in 2021 in the setting of an admission for HFrEF, and more recently is 2.7. His HFrEF was felt to be due to poorly controlled hypertension and heavy alcohol use. His EF has now normalized after stopping alcohol. His past medical history is there. He has CKD, he has major depressive disorder, PTSD, anxiety, and alcohol use disorder, hypertension, as well as OSA, for which he is not currently actively using his CPAP. You can see his medications there. More pertinently, he's on sertraline as well as bupropion. When I saw him recently, his blood pressure was 156/94 and told me that he ran out of medications the week before and hadn't gotten around to getting any refills. He also told me that he had started drinking again, mainly at night to help him relax, to sleep better, and deal with his stress. He told me that he can't miss work and therefore doesn't have time to re-engage with mental health, but he assured me that he would be just fine. So today, I'd like us to hopefully by the end of our session to be able to assess the epidemiology of depression in CKD, differentiate methods of depression identification used in CKD studies, as well as recognize the association between depression and depressive symptoms as well with poor clinical outcomes, appraise some of the data on treatment in depression, and then as well articulate some potential mechanisms that underlie depression and their role in poor outcomes, and possibly even in treatment, and then explore future directions. So, according to the National Institutes of Mental Health, major depression is one, if not the most common mental disorder in the United States, and it indeed carries the heaviest burden of disability among those with mental health disorders. And depending on your source, prevalence ranges anywhere from 2.2 to 4% in the general population and a little bit higher in the primary care setting. So as we know, the CDC tells us that approximately 15% of Americans, that's 37 million people, have non-dialysis CKD. And this does not include the dialysis population. As we heard earlier, that population is about 800,000, according to the latest USRDS data. So depression is felt to affect about 20 to 25% of adults with CKD. And this is in contrast with other chronic diseases. For example, diabetes, a little bit lower at 12 to 18%, congestive heart failure around 15%, coronary artery disease 15 to 23%, and COPD is actually quite comparable at 25%. So where does this prevalence on CKD and depression come from? Well, it comes from several studies, but the most frequently referenced study is this systematic review and meta-analysis that was done by Sutonia Palmer et al. She and her group looked at about 216 studies, which included over 55,000 people. Now, the majority of these studies were dialysis, but there was a proportion, about 16 studies of non-dialysis patients, which made up about 3,500 people. Though of note, it only comprised about just over 6% of total. It also included some transplant studies, though it was characterized by smaller sample size, mostly European. And the majority also diagnosed depression or identified depression via a patient or clinician administered questionnaire. And we'll talk about what that means in a few slides. So what did they find? All right, so focusing on the non-dialysis population, you can see that the prevalence when using a patient or clinician administered questionnaire is about 26%. And this is compared to, again, with this method of 39% in dialysis. And you can see that that difference is significant. Whereas with the interview-based, you can see that the prevalence is a little bit lower. Here, let me bring this in. There we go. At 21%, as compared to dialysis, there's about 22%, and that difference was not significant. All right. So why might that be? Well, current diagnostic algorithms begin with screening for depression by identification of depressive symptoms via the self-reported questionnaires. And these can be administered or done either directly by the patient or administered by the clinician. A formal diagnosis then requires a more detailed evaluation or clinical interview that utilizes DSM-5 criteria. So here's an example of some of the questionnaires that are used and the clinical interviews. You can see here that the Beck Depression Inventory or BDI, as well as the Quick Inventory of Depressive Symptomatology Self-Report, or the QIDS-SR, have both been validated actually against the mini in non-dialysis populations. So why might depression prevalence be higher when using a questionnaire in CKD? Well, this has been attributed to the overlap of somatic symptoms of depression and somatic symptoms related to more advanced stages of chronic kidney disease, such as fatigue, difficulty with concentration, poor sleeping, poor appetite. And so thus these quote unquote uremic symptoms theoretically can be distinguished from true depressive symptoms during the clinical interview. And for this reason, when using the self-reported questionnaires with more advanced chronic kidney disease, such as dialysis, higher cutoffs essentially are used to screen or identify depression. All right. Okay, so we have depression prevalence and diagnostic approaches, but really the larger question is, what does this mean for our patients? Several studies have looked at the association of depression and clinical outcomes in non-dialysis CKD, and we'll take a closer look at a couple of those studies. The first study that I would like to discuss is a VA study, and I think therefore pertinent to my patient, Mr. B. Susan Hedayati et al. Did a prospective cohort study on 267 patients with CKD stages 2 to 5 at the Dallas VA, and recruited patients over a period of about 6 months and then followed them for a year. Depression was diagnosed by blinded personnel using the clinical interview, the mini clinical interview, and they looked at a composite outcome of death, dialysis initiation, or hospitalization, and secondary outcomes of each of these were assessed separately. So this table shows us rather the event by depression status, findings. And though not noted here, depression occurred in 21% of patients, and that's in keeping with our prior review. So focusing here, the composite event, that is death, dialysis initiation, or hospitalization, as you can see, occurred in 60% of depressed individuals versus 41% of non-depressed individuals, and this difference was significant. And also not noted here that the mean time to the composite event was significantly shorter in the depressed group compared to those without depression. Hospitalizations, as you can see, also occurred more frequently in the depressed group versus the non-depressed group, and this was also statistically significant. The next study that I wanted to discuss is out of Taiwan. Tsai et al. Did a prospective observational cohort study looking at the association of depressive symptoms of depression and progression of chronic kidney disease. Let's see, where was I? Sorry. They looked at 428 patients, again, with non-dialysis CKD, and followed them for 4 years. The primary outcome was also a composite outcome of ESRD and all-cause mortality, and the secondary was first hospitalization. Now, they identified depression through the depressant symptoms, rather, through the questionnaire, the BDI. Again, that one has been validated. So here are the event results. So you can see that in the total cohort of 428 people, 160 patients were found to have depression. This is 37%, so higher from the prior study that we looked at. And this may be due to the fact that a questionnaire, a screening questionnaire, was used. For the primary composite endpoint, you can see that 43.8% versus 24.6% of patients were found to have the primary outcome. And hospitalizations as well were higher in the depressed group. So not shown here, not shown here is that participants with high depressive symptoms had a more rapid GFR decrease and a higher eGFR at dialysis and initiation. And this is an important study, I believe, and worth talking about because it tells us that depressive symptoms as well can be associated with poor outcomes in chronic kidney disease. Okay, so what about treatment? Can we limit depression and/or depressive symptoms and impact poor outcomes? Well, with a few notable exceptions, most studies of antidepressant medications in patients with chronic kidney disease have been limited, mainly by lack of a placebo arm, small sample size, inadequate dosing, or inadequate duration of treatment. Most also have investigated the effects of the SSRI class of medications, mainly because this has a quite favorable cardiovascular profile. All right. So the CAST randomized clinical trial is one of those notable exceptions. Again, Susan Hedayati, she's done a lot of work on this topic. She and her colleagues did a well-powered, randomized, double-blinded, placebo-controlled, multi-center trial to investigate the efficacy of sertraline versus placebo in non-dialysis CKD. They again used a VA population, but in addition used a non-VA population. They diagnosed depression initially through the clinical interview, and patients were randomized to sertraline versus placebo for 12 weeks. Sertraline dose was titrated up to a maximal tolerated dose, and their primary outcome was improvement in depressive symptom severity from baseline to 12 weeks as determined by the QIDS questionnaire. Secondary outcome was improvement in quality of life via the KDQOL survey. So what did they find? Well, you can see here that both groups began with a score of 14, and this correlates with moderate depression. They also dropped about 4, and you can see over time that the scores were nearly identical, and they basically followed a very similar path. And in the end, there was no significant difference between the sertraline group and placebo. There was a 32% drop in the sertraline group versus a 25% drop in symptoms in the placebo group. And then again, but again, these were not a statistical difference, but these percentages will be important in a moment. Also not shown here is that there was no improvement in quality of life via the KDQOL survey. Also not shown is that side effects such as nausea, vomiting, diarrhea occurred more frequently in the sertraline group versus placebo, and there was a statistical significance there. So why no difference? SSRIs are effective, have been shown to be effective in the general population. Why not in chronic kidney disease? I think looking deeper into this question will highlight issues around treatment of depression in general, and more specifically in chronic kidney disease. So what about the design? Well, the design, as I described earlier, was really quite good. So it was not a design problem. What about this concept of a high placebo effect? This has been postulated in prior studies and even in the general population as a potential reason for not seeing a positive effect with treatment. But it's been sort of determined that if you can maintain a placebo effect below 30%, you should be able to see a difference with your treatment. And as we can remember, the placebo effect in the CAST trial was only 25%. So this is really not considered high. Not high enough of a dose. This has been a criticism of other studies in the past. Well, as you know, they titrated the dose up to the maximal tolerated. So the dosing shouldn't have been a difference. What about socioeconomic factors? Well, they impact our patients in many ways, and most specifically, and not mentioned in this particular case, 85% of the participants were unemployed, and unemployment or lack of employment has been associated with decreased antidepressant treatment effect. All right. Oops, sorry, getting ahead of myself. Was depression perhaps not severe enough? So as you recall, both groups were really felt to be moderately depressed in the beginning, and this even in general population, treatment of moderate depression can be controversial and is not always effective. Of course, not surprisingly, people with higher levels of depression tend to respond better to therapies. Were the symptoms perhaps not due to depression? Well, as you recall, there was a clinical interview that was used to diagnose the depression initially, and then the survey was used to monitor symptoms. So most likely the symptoms were due to depression. Duration treatment, again, it was 12 weeks. And in the general population, you can see response. There was response seen in up to 3 to 6 weeks. So really the duration should have been long enough. And then what about drug metabolism? Well, certainly drug metabolism is different in CKD. And as we know with the CAST study, there's lots of side effects that may be higher, in fact, in patients with CKD. And this certainly can lead to non-adherence of medication. So this may be at play. Okay. However, I think the real question is depression and CKD just different? The results of the CAST trial actually are in line, though, with an increasing body of evidence from well-powered trials in other chronic medical conditions, such as asthma, ischemic heart disease, and congestive heart failure, that SSRIs are really no more effective than placebo for treating depression. So does the fact that CKD commonly exists with other illnesses make depression and CKD even more difficult to treat or even resistant to treatment? Or is there something about the underlying pathophysiology of depression and CKD and other chronic diseases for that matter that leads to poor outcomes and makes these individuals non-responsive to SSRI therapy? This figure depicts some of the potential mechanisms that underlie depression and lead to adverse outcomes. So depression may, in fact, contribute to CKD or be caused by CKD. And behavioral as well as biological mechanisms may contribute to adverse outcomes through either unidirectional or bidirectional relationships. So for example, the burden of illness of somebody who has CKD may make them feel depressed, and their depression may lead to non-adherence of medications and non-adherence to self-care, and therefore uncontrolled blood pressures, blood sugars, et cetera, leads to cardiovascular events. So this is one potential loop. Biological, focusing on inflammation, several studies have supported a bidirectional association between inflammation and depression and chronic illness. And this association is particularly relevant in our patients with CKD in whom inflammatory levels are high. So as we know, inflammation can accelerate atherosclerosis and lead to cardiovascular events. In fact, a pre-specified secondary analysis of the CAS study found that inflammatory biomarkers were associated with the somatic symptoms of depression, and those with a higher C-reactive protein were felt to be possibly more likely to benefit from sertraline. So a possible avenue of future study. So where does this leave us? Well, depression is common in chronic kidney disease. Depression is associated with poor outcomes. Commonly used antidepressants don't work any better than placebo. So is there no hope for Mr. B? Let's go back to Mr. B and just get some updates, specifically on his treatment. So he was started on sertraline in 2015 and reported little positive effect on his mood. He was started on bupropion more recently in September of 2021 after his hospitalization, and doses were increased in November, and he did report some improvement. He also reported some improvement in his mood during group activities and individual counseling that he received when he was part of the ATC, the Addiction Treatment Center here at the VA when he was trying to stop drinking. And this was actually something that he did back in 2017. So looking back at the CAS study, I think it is important to remind ourselves that sertraline does help, right? But placebo also helps. There's just no difference. And depressed patients who are part of studies who are treated with a placebo do receive support by meeting regularly with clinicians, research assistants to discuss symptoms, et cetera. And this interaction can instill hope and even raise expectations of improvement. And this is part of the underlying thinking as to why placebos can help. So being in a study is almost a type of psychotherapy, we could say. From the general population, actually, the most effective treatment is felt to be, our treatment plan is felt to be one that's a combination of both pharmacotherapy and psychotherapy. And in fact, we know that Mr. B did best when he had both. So what evidence do we have that psychotherapy works in chronic kidney disease? Well, this is the ASCEND study, and it was a multi-center randomized trial that compared the treatment of sertraline versus cognitive behavioral therapy in patients with end-stage kidney disease, so not non-dialysis. And it was headed by our fearless leader, Dr. Raj Mehrotra. So Raj and his colleagues compared maximally dosed or maximally tolerated rather sertraline versus cognitive behavioral therapy that was administered during dialysis over a course of 12 weeks. And they did find improvement in depressive symptoms in both groups. And though there was a modest and even statistically significant benefit of the sertraline over the cognitive behavioral therapy, the absence of a control arm meant they really couldn't answer the question if either of these therapies were better than placebo. Which brings us to the Concord study, which Raj is also a part of. And it's a study that's currently undergoing recruitment. They're still actively recruiting. And this will be a study in non-dialysis patients. And it will involve patients from both the UW as well as UT Southwestern. And their hope is to reach a goal of 210 patients. And what they've done is they've designed a randomized placebo control blinded study, again with a non-dialysis population, that's going to look into the response of pharmacotherapy, this time with bupropion, and psychotherapy in the form of a therapy called behavioral activation therapy, or both therapies. So they will be looking also into the effectiveness of combination therapy. So they plan to investigate both the efficacy as well as tolerability, and also look into some patient-centered outcomes, including adherence to medication, healthcare visits, fatigue, sleep, and overall functioning. All right, so in summary, 20 to 25% of our non-dialysis patients experience depression. Their depression is associated with poor clinical outcomes. And standard pharmacotherapies do not appear to be superior to placebo, but both are effective. And the addition of psychotherapy may have a therapeutic advantage and is worth promoting and exploring, as it looks like folks are already doing. So effective treatment, hopefully in the end, will improve our patients' clinical outcomes. But really, I think engagement in any form that it might take with our patients on the topic of depression can give them hope. And so the answer to my original question is yes, there is hope. And that's all I have. Questions. And hopefully this image gives you some hope. Sunny skies on a beach, flying a kite. How great does that get?
Thanks, Maggie. I like the uplifting ending.
Yes.
Raj has a question.
Well, a comment and a question. I think, Maggie, that was fabulous. I think you did an amazing job. Your last bullet that you had in your conclusion slide probably is very important, is the, what is, after all, within quotes, the placebo effect in treatment of depression is actually engagement with patients, talking to them about how they are feeling and offering them support, whether or not with the medications. I think that is critically important. Placebo effect in trials of depression is well established.
Yeah.
I would just have two more points to make. The second thing is that in studies in people on dialysis, cognitive behavioral therapy, the two separate trials that show is better than no treatment.
Yep.
Results in greater improvement in depressive symptoms. And when I juxtapose that against the study that we did, where that says sertraline was better than cognitive behavioral therapy, which in turn in two trials has been shown to be better than no treatment, I am not ready to give up hope with drug therapy, including with SSRIs. And the final point, so we have to be very careful and not, yes, CAST is the one trial in people in CKD, and I would be careful and not to say that there is no effect. The third thing is that one of the things that we've recognized is that in people with kidney disease that have depression, they have particularly severe coexisting anxiety. Mm-hmm. When you're not dealing with the anxiety along with depression, so not all SSRIs are useful for the treatment of anxiety as well, but not all SSRIs are equally effective. Mm-hmm. So for example, escitalopram, for example, is something we want to propose in our next study, is more effective in addressing anxiety than sertraline. So it may not be a class effect, it may be also, and similarly with behavioral therapy, if the behavioral therapy also does not address anxiety along with depression, it may not be as effective. But anyway, I think you did a fabulous job. Thank you.
Thank you.
I'm curious, Maggie, as a primary nephrologist, especially since you're describing these kinds of overlapping symptoms with symptoms of kidney disease and mm-hmm. unique kind of depression in people with advanced kidney disease. How do you see your role as a primary nephrologist, and how do you maybe work with primary care docs and things for treating depression?
Yeah, I think this just underlies the importance of a collaborative approach and engaging, making sure that our patients do have good primary care relationships. And, at the VA, probably the best way to connect people with mental health is through their primary care provider. It's very well established. So engaging the primary care, making sure primary care knows what's going on. And I think with Mr. B, that was very effective. His primary care provider helped him to connect. But again, I think especially with him, he does have this anxiety. And I think it's really hindering him from reaching out and taking the opportunities that he does have. I think at the VA, we have the resources there, but the decision and the acceptance and the engagement has to happen. But I think we are challenged, as all providers are, of, we only have so much time, and what do we focus on, and what's the most important thing? And I think, always coming back to the patient and what that patient really needs in the moment, and sometimes spending more time on depression instead of high phosphorus is really better off for the patient.
A lot of agreement from the chat.
Oh.
Unless there are any of the last quick questions for Maggie, I will, we can close. And thanks for 3 excellent speakers. And everyone have a great weekend.
Yes. Thank you for taking over the helm. Bye.